from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about neurological rehabilitation and spasticity management. Our guest today is Dr. Ryan Hafner, a physiatrist at Sarasota Memorial. Dr. Hafner, thank you so much for being with us.
Thank you for having me.
Let's start with the basic question. What is physiatry and why did you choose it?
So, very common question that a lot of people ask. Physiatry, also known as physical medicine and rehabilitation, as a formal medical specialty, is all focused on patient function, which is a clear, stark contrast between us and other specialties. You know, you think of an eye doctor, your kidney doctor, or your brain doctor, right? We kind of traverse across a few different spectrums of different specialties, all with regards to patient function. So that might come in the form of movement. It might come in the form of pain issues, bowel and bladder issues, etc. So anything that limits your ability to do whatever it is that is keeping you from, doing your job or doing activities with your family, can really encompass across a lot of different things.
And then I want to talk about kind of your subspecialty within physiatry. You really specialize in neuro rehab and spasticity management.
Yeah.
What does that mean?
Yeah, of course, yes. So neuro rehabilitation is really a fancy term for talking about all the complications, all the sequela after a neurologic injury. So it's very common for patients and providers to focus on the initial stroke itself, the diagnosis of the stroke, the treatment of the stroke, and how to prevent the stroke from happening again. Where I come in and where my whole team comes in is really focused on not just the diagnosis itself, but knowing and understanding that this is not just a one-time injury. This is now a chronic condition that can develop and evolve over time. That is not something that you have just from the start, but can change over time as well.
And it's not just stroke patients that come to you. Who are your patients?
Exactly. My patients that I typically see will have either a stroke, spinal cord injury, brain injury, whether that's traumatic or non-traumatic, cerebral palsy, multiple sclerosis, other forms of what we call upper motor neuron syndrome, as well as what we consider typical patients in our specialty as well, which could be anywhere, any sort of pain syndrome, low back pain, knee pain, as well, anything that really limits your overall function.
And how does neuro rehab differ from rehabilitation for other injuries?
Yeah, so neuro rehab is a specialty within physiatry where it's really focused on each individual patient. Every patient, depending on their neurologic diagnosis, will present very differently from each other. So even within your population of stroke patients or patients with a stroke, they might have different complications of said stroke. As opposed to your patient with knee pain, from the arthritis of the knee pain, it's just a very focal problem. Patients with, say, for example, stroke might have issues with, physical function, movement, coordination, balance, sensation, right? Cognition, language deficits, swallowing issues, emotional and psychiatric complications. So really, to adequately take care of these patients, you have to understand not just what the initial diagnosis was, what's the sequelae, what are all the complications leading from that, who were they prior to this injury, who do they picture themselves as now, and where would they like to be in the next year and 5 years given this.
What do you think is the biggest misconception that patients have when they come to see you? Let's say they're referred to you after a stroke or a spinal cord injury or any of the other diagnoses you referenced before they come in. What do you have to clarify to them most often?
Sure. I think the biggest thing, as I mentioned, is I think a lot of focus, especially in the acute side of the hospital, is focused on the diagnosis, the initial treatment, and prevention of that, pathology from happening again. Where I come in is, improving awareness and education for these patients that, you've had this diagnosis, but this is not a matter now of you've been in the hospital, now, you're going to live with what you have. Understanding that, number one, new complications may arise as time goes on as a result of this injury. Number two, even though you have complications, your recovery is still ongoing as well, right? So even though you might have new problems, new issues as time goes along, the neuroplasticity, that's the fancy word for kind of talking about the recovery of the brain itself, happens months after the injury itself. But then thirdly, understanding that, for me, my role in your care happens the day that the injury occurs, for as long as you need my help, right? One of the saddest things that I think I come across for patients out of all the diagnoses that I've listed, for patients who suffer from these types of ailments, the saddest thing that I see is when they get lost to follow-up. That they receive the initial care at the hospital, they get some rehab, maybe in an inpatient facility or a skilled nursing facility, but then are discharged without any plan of care after that. And that, to me, is really the sweet spot, I guess you could say, to make sure that we keep improving, that we keep making progress, and that you don't fall through the cracks.
What are the main areas of focus for this type of rehab, this neuro rehab?
Sure. So particularly with my training, I actually did a fellowship in spasticity management. Spasticity is a fancy term for what patients oftentimes will come in saying that they feel stiff, they feel tight, they're having muscle spasms. Some people might have posturing, or what they would call them deformities, I guess if you could say that as well. It's a whole spectrum of complications resulting from all these different ailments that I mentioned that can actually be improved upon and can actually be treated intentionally to help patients with, whatever their goals are. And everything that I do is goal driven by the patient themselves, right? So if the goal is to improve their walking, their goal is that they don't have a functional arm at this point, but we want to open up the hand just enough so they can hold a cell phone, or that they can reach out for an item more easily. Some patients come in with the goals, maybe they have significant deficits where the goals have changed to ease the burden of care by other caregivers, whether that is to perform hygiene to the patient, whether it is to don and doff clothing. All these different things are complications of something called spasticity and other fancy terms that really kind of affect people. In addition, the spasticity and these other complications can cause pain on the joint. And simply for some patients, it may not affect their overall functioning, but they don't like the body image. Some patients, they might be able to use that affected arm. A very common posture for a stroke patient is to kind of have that elbow flexed and the kind of fingers bent in like that. And when they're walking around like that, they might be able to use this arm, but they don't like how this portrays to other people, and it shows them, hey, I've had something happen to me. So again, for each patient, it really depends on what their goals are, and I try to meet them at those goals, right? Everything that we talk about, I always say they're the leader of the team. So I'm here to support you in any way that I can. Many times in terms of goal setting, we have to make sure that, I understand what their vision is for where things are in a year or 5 years from now. However, if somebody, say, was a professional pitcher prior to this and they had a very devastating stroke, we have to make sure that the goals are also, somewhat attainable too, that we're making sure that I'm helping them in a way that is realistic. And I think, just to make sure that we're not letting anybody down. So kind of finding that middle ground of where do you see yourselves, how can I help you get there, and then what's achievable here.
I know you say that rehab looks different for every patient, but are there some things that are very similar, or is there any kind of guide that you use for most patients who have experienced similar injuries or similar diagnoses?
Yeah. So for patients, and really we're talking about two separate things. I know Dr. Papuchis in a previous podcast had talked about inpatient versus outpatient rehabilitation. In terms of the inpatient side of things, which I will also be working with patients at Sarasota Memorial Hospital. On the inpatient side of things, there are clear algorithms and evidence-based therapy regimens for different populations. I think Dr. Papuchis had mentioned in the inpatient rehab facility here at SMH, we do have gravity assisted or weight assisted therapy to be able to kind of hang from a harness and to be able to take off as much body weight as possible, to give people total flexibility and freedom to kind of push themselves further than they would otherwise. So definitely on the inpatient side, there are, with working with wonderful therapy colleagues on the side, they have really great systems in place to make sure that they're getting the right therapy at the right time. In terms of the outpatient rehabilitation, that's where it becomes a little bit more creative. As I mentioned, a lot of people do seem to kind of fall through the crack, unfortunately. So my goal is to try to find as many of those people as I can and try to help as many of those people as I can. And in regard to that outpatient or that kind of long-term follow-up, that really does kind of depend on what is their recovery that they've experienced. Again, what are their goals? And it really, we know the science, but a lot of what I do and how we treat it is actually mostly an art, in terms of what are their goals, how can we get them there, and between two patients who have the same diagnosis, that may be very different.
You referenced a little earlier the team that you work with. Can you talk about the importance of therapy, co-treatment, and collaboration when it comes to specifically neuro rehab?
Of course. Yeah, in terms of working as a team, really within the realm of rehabilitation, us as physiatrists need the others to do our job well. In terms of especially on the inpatient side, our therapists, our nurses, social workers, case managers, this is really a large effort to get these patients in the right spot and a safe spot for them once they're discharged from the hospital. In terms of the therapists, for me personally, many of the treatments that I offer, whether they are nerve blocks or botulinum toxin injections, intrathecal spinal pump management, and other procedures, everything that I do, I can't do what I do well without good therapy. Many of the things that I do, if I do the procedure, then the patient goes home and just sits around and doesn't move them, they don't move at all, it's not going to work. And so really, what I like about this relationship that we have with therapists, the biggest thing that I tell people to explain my role versus the physical therapist role, because those are two separate things. I don't pretend to be a therapist, right? I say when you look at the mental health world, right, you have a psychologist and a psychiatrist, right? The psychologist is going to do the talk therapy, right, and work through multiple sessions with you. The psychiatrist, as a medical doctor, will prescribe the medications and whatever other therapies are required for the diagnosis. So in a similar fashion, in the physical medicine world and the rehabilitation world, I am able to provide medications, injections, procedures, and evaluations in tandem with the therapist who will do the stretching, range of motion, transferring, walking with them, and doing all those things on their end, right? So between the two of us, we really work well together, and I'm dependent on them for what I do.
How do you decide which patients need oral or topical medications, or some of these procedures you've mentioned, and not just physical therapy? How do you decide which patients need both or only one?
Yeah.
What does that look like?
So there's kind of two scenarios in which that happens. If the patient comes into my office and notes symptoms that they're having, whether if it's pain, if it's spasticity, whatever their ailment is that they're coming in with, hearing reports of what is happening at home, maybe where things were at a few months ago and then where things are at now, that'll kind of help steer me in a direction of what's going on. If the patient is actively getting outpatient therapy, or if they are on the inpatient therapy side, and reports from therapists and other affiliated staff, talking through what's going on during the therapy session. Medications really come into play when they are not progressing in therapy like they should. And they're typically for reasons that are out of control for the patient. Again, if it's pain, muscle spasms, other things that we can actively manage, that's really when medications come into play.
When should a patient who has had a stroke, for example, or one of the brain injuries you mentioned, or spinal cord injuries, when should that patient or their loved one seek out neuro rehab or therapy for them?
Sure. My answer to that is immediately. One of the things that I'm going to really, really hope that we can make progress with here at SMH is to be a part of that as soon as possible. Again, as I mentioned, complications arising from each separate injury can appear at many different times. For some people, they might have a lot of issues or a lot of symptoms that they're feeling right away. For some patients, it may develop over the span of weeks to months. And so again, to make sure that they're not falling through the crack and that we're not losing them to follow-up, ideally, I'd like to see them, even if they're maybe not having symptoms at that time. In today's world, acute care stays are short, right? And there's more and more pressure to not maybe stay as long. And physicians are understandably very busy as well. So that's just kind of today's healthcare environment. And so, you have a lot of patients, a lot of families that leave the hospital saying, we know what happened maybe, but we don't know anything of what to expect, a month, a year from now. And that's really where I come in. If nothing else, to establish care with these patients, to talk through that, to educate them, and to be available to screen as time goes along. I'd much rather have the scenario in which I find something on screening the patients and watching how they walk, a few months later, rather than many scenarios in which I've been a part of in the past where, I see a patient maybe in a skilled nursing facility who has had a significant decline, where I walk to their bedside and I think to myself, man, I really wish I would have seen you 5 years ago when we could have done more for you. So I really want to try to stay on top of it as best as possible. And I think SMH and its wonderful facilities and staff, I think will help us do that.
If someone is listening to this podcast or seeing this and says, I could use this, or my loved one could use this, a friend I know could, how do they go about seeking out this kind of care?
Of course. Well, really in terms of the initial contact, smh.com has wonderful resources available. They can certainly search my name on there, and that will give the clinic name, fax number if it's another provider that wants more information, and we can definitely get a hold of them in that regard.
Why do you think so many patients wait so long after a stroke or injury to seek rehabilitation or this neuro rehab like you're talking about?
Sure. I think really in that regard, I think it's a lack of education and a lack of awareness, and to no one's fault, right? It's a very scary time for a lot of these patients and for their families. This is a huge change in their family life, their life at home, and so there's just so many components to this that I think are just hard to kind of keep all under one list. And I think it spreads not just to patients and families, not necessarily understanding how things will unravel themselves over time, but also primary care physicians, others of my colleagues in the community who might not necessarily know that these treatments are available. And for a lot of these patients, their primary care physicians and allied health are the first point of contact for a lot of these patients. So I really think it's kind of a mix of educating patients and their families from the get-go to let them know what to expect, as well as those initial contacts, right? Those primary care physicians, educating them on when you see a patient with this diagnosis or with these symptoms, here are the resources, here's what we can do, please have them come to my clinic.
Can you talk about the collaboration you have with HealthFit and how it helps your patients?
Of course, yeah. So I'm very excited coming on board here at SMH to learn more about HealthFit and all the wonderful resources that they have. I'm a big proponent in move, right? So after their inpatient rehab stay, and even some dedicated therapy sessions beyond that, I want my patients to keep moving, right? I don't want them to sit around. I want you to move as much as you can, right, to within what you can do. And I think HealthFit provides a source for patients to do that, to keep moving, because we all know that the benefits of physical health and staying as active as possible, it doesn't just help the initial diagnosis, helps everything else too. So I'm excited to collaborate with HealthFit and hopefully come up with some engaging and fun programming for these patients.
Dr. Hafner, thank you so much for joining us today. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.